Good afternoon, everyone. This is Christine Friedenreich speaking. I'm the Interim Scientific Director for the O'Brien Institute of Public Health, and you are joining us today for another one of our COVID-19 digital forum. Today's forum, Anatomy of a Pandemic, is entitled Planning, Response, Human Toll, COVID-19 on the Front Lines. Okay, the slides are not advancing. This series has been initiated by us to showcase some of the work of our O'Brien Institute members and also the wider University of Calgary community. We're trying to show what we're doing to support authorities and governments in their response to the unprecedented scale of and human cost exacted by the COVID-19 outbreak. This particular webinar and our previous ones are being recorded, and they can be found on our O'Brien Institute website. I would also like to highlight that a lot of the work that has been done by our COVID-19 University of Calgary Task Force, and these are the members of that task force, and we have been working since mid-March to assist authorities within the City of Calgary and also the province of Alberta in their planning around COVID-19. Today's speakers, this is the first time that we're very fortunate to have 4 speakers for our digital forum, include 4 individuals who are listed here. Dr. Evan Minty is a general internist who splits his time between clinical practice, applied clinical informatics, and applied machine learning projects with Alberta Health Services, supporting their EMR deployments and decision support development. He is the co-lead of the Calgary Medical Emergency Operations Physician Pandemic Response Plan. He's joined by Dr. Aleem Bharwani, who is the Director for Public Policy and Strategic Partnerships with the Cummings School of Medicine and the lead for public policy at the O'Brien Institute for Public Health. He's a specialist in internal medicine and a co-lead of MEOC. We're also joined by Dr. Sachin Pendharkar. He is a respiratory and sleep physician at the Foothills Medical Center and an associate professor in the Cummings School of Medicine. As a co-lead of MEOC, he brings expertise in the design, implementation, and evaluation of innovative models of healthcare delivery. And finally, we have Dr. Gabriel Fabreau. His clinical practice is as a general internist, and he focuses on caring for socially vulnerable populations, specifically as an inpatient internist at the Peter Lougheed Center, as well as an embedded consultant within the Mosaic Refugee Health Clinic and the East Calgary Health Center. He's also a co-lead of MEOC. So today we will have a number of ways of communicating with us. You can use the question and answer box, the chat box in Zoom, to send questions to our panelists. You can also use the comment box on Facebook Live, and you can also send us any comments on our Twitter at O'Brien COVID-19. So now I'm going to hand it over to our speakers, and they will do their presentation, and then after that, we will have time for questions and answers. Thanks very much.
Go ahead, Gabe.
Okay, yep, sorry. Okay, thanks very much, Christine, and to the O'Brien Institute for Public Health for the opportunity to present some of the work that we've been doing over the last 6 or 7 weeks with large teams. Next slide, please. So I'll just start by saying we have no disclosures at all for the work that we're presenting. We use first-person inclusive language, and it's important to also acknowledge the traditional territories of the Blackfoot, the Treaty 7 people, including the Siksika, the Piikani, the Kainai, the Tsuut'ina, Stoney Nakoda First Nations, and also the home of Region 3 Métis Nation of Alberta. Next slide, please. So the work that we're going to present today is on behalf of many, many people. We are just one very small piece of the larger pie in the health system and broader community that's been making massive efforts on behalf of the community for preparedness for the COVID-19 pandemic. So it's a very short list, includes ECC, which is the provincial level emergency central command, public health, acute care, ICU, community care, the University of Calgary, and many, many others. Next slide, please. If you can hit the space bar once, perfect. So this is, you know, this is where we were when we started. I went to the PLC to get fit for my 95 fit mask as a practitioner that traditionally cares for patients with respiratory illness, and I personally have some as a public health researcher, and my research includes refugee health and some humanitarian response. I have some disaster medicine training. I put up my hand and asked if I could help, be of some use, and then you know, 6 weeks of our lives disappeared. The very next day, you know, 3 or 4 of us got together, and with a team of about 30 internists, started working very hard to start to plan for the what started with just within our own internal medicine division. At that time, as you can see now, if you hit the spacebar again, where we are, this is a slide that shows the case volumes in Alberta. You know, at the time in March 13th, we had a 3-day doubling time, and we're looking at exponential growth, and there was a lot of unknowns. Thankfully, this curve can clearly show you that it's not been exponential, but there's been many things that have transpired since, and many which were, as I mentioned before, were unknown. So we're currently in the Calgary zone, 68% of the cases in Alberta, and at the time, although we had a bit of a disproportionate case count at that time, no one expected to last for this long or to continue to be this disproportionate. Next slide, please. So everyone has, I mean, if you have a TV or an internet, you have heard about the curve and the shape of the curve and what we would like to do to the curve. This is a slide from the Public Health Agency of Canada that they presented 2 days ago. And what it shows you is, I like it, it's a very simplistic figure that shows you what it is that we're trying to accomplish. So the blue line is, and the curve, that bell-shaped curve, is the number of COVID-19 cases in our communities. And all of us together, with the massive implementation of public health measures that we are all a part of, are working to bring down the peak of that curve. And we're trying to bring it below the dotted line, which is the current capacity of our healthcare system. And then us as acute care physicians and working within acute care and Department of Medicine, we're one small part of a broader, massive collective effort on behalf of the healthcare system to try to bring up that dotted line and all the different factors and features that are required to increase the capacity of the healthcare system. Next slide, please. So again, at the time in March or mid-March, we were using and extrapolating global data that showed that although we had not enough data in our own hands, empiric data from Alberta or Calgary, we had broader projections from other places, starting of course with Wuhan in China, that gave us some understanding of, you know, the grand majority of the cases that we expected would be mild and folks would do very well and be able to recover at home with some support in the community. But we were really worried on the acute care side about the 15 to 20%, which are more severe infections, and then the 5 or 7% with critical care, which are the patients who require mechanical ventilation and intensive care supports. If you look at that curve in Canada, we match it, but in Alberta, I just put up the numbers that from yesterday that show that we are significantly below. And again, we had no understanding that that would be the case at the time. We could talk about that later, but there are many factors probably related to the fact, to the reasons that we're seeing lower overall proportions. A lot of it has to do with our early and continued testing strategy in Alberta. Next slide, please. This is another slide from colleagues from the University of Calgary. So this is from the Center of Health Informatics and colleagues of ours that we work with. It just shows you where Alberta is in the green line, Canada the red line, in comparison to peer countries. And this is a collective linear curves of multiple countries. And you can see that, you know, if you go way back to the start where all those dots are, that's where we were. And you could see the the dotted line that Alberta was following was a 3-day doubling time, which was really, really scary to start with. And you can see that that curve has dropped as we're crossing those dotted lines in the middle, but it certainly hasn't flattened. So if you look at China, that's a curve that is flattened, and that means that there's not any more or very few new cases. And I think collectively, every jurisdiction in the world is trying to get to a curve that looks similar to that. Next slide, please. So like I said, at the time when we started, we were looking, everywhere in the media, we were looking at images like this. So this is some images from New York. This is a field hospital in Italy, and in mid-March, early April. So we had, we were certainly being fueled by a collective fear that our healthcare system might be facing similar volumes. And at the time, we were really working with the fear that we would be facing, a tsunami of patients that might overwhelm our healthcare system. Next slide, please.
Thanks, Gabe.
Yep.
And so, as Gabe mentioned there, we're used to planning in healthcare and other systems against linear growth trends. So Gabe showed a slide there that, showed efforts, for example, to raise that red dotted line, in his slide to kind of increase the healthcare capacity. That's something that we are used to doing, but really only against slow linear growth. And it's really important to recognize and contextualize planning efforts against a very different growth model here. And that's one of exponential growth, which is the growth curve that's followed by the spread of a virus when that's unmitigated. And so I do think it's illustrated to just think through just a quick example of what that can mean. So if you pretend, for example, that you're going to fill hospital beds through an exponential process and that they're going to be full in 60 days. And for simplicity, let's just assume that our doubling time is 1 day. Just think in your mind, what day are you half full? Next slide, please. And that answer is a bit surprising when you first see it in print, but really can kind of be seen as obvious in hindsight. If I'm doubling every day, then I was half full the day before I was full. And then the day after that, I have twice as many patients as I can handle. And that's the unforgiving math behind the stories of Wuhan and Lombardy and others. The accounts that you might have read of just explosions of patients, or even the feeling in the general public that nobody really had coronavirus until everyone had coronavirus. It's also why complacency can be so dangerous. And we haven't arrived here. And that's because Albertans, by and large, have held the line. The community at large has bought the system time. That time has been purchased at enormous cost. And we want to first and foremost acknowledge the cost there that many people are suffering, and we're all struggling through this, but there are areas that are struggling more than others, and we need to feel for those people. We want you to know that we haven't taken that time for granted. The time that you guys have purchased is our single biggest ally. That time has been purchased through your sacrifices, Alberta Public Health, the people and the facilities at their front lines, and their exceptional work. So as an example, something that wasn't really widely advertised, Calgary had the first drive-through testing site in North America through the work of some folks at the former Children's Hospital in Richmond Road. Our laboratories, our medical students, and other contact tracers, they've done an exceptional job. As a physician community, which again, as Gabe mentioned, is a small part of a bigger whole, we're using this time to fight with you. And how we have used that time and who that community is really what frames the rest of this talk. We've used it to provide a surge in governance support grounded in principles of crisis and disaster management, to create a staffing model that has a chance of scaling up against the reproductive rate of viral RNA, and to recruit other physicians into the fight, to train them and ourselves through online modules, webinars, simulation, drilling, in the use of personal protective equipment, for example, to create knowledge products that will help us scale up care, to be more data-driven in our response, and to hit back through the organization of our own participation in clinical trials, and to create and lead our own. Next slide.
So we had no idea how bad things could get. And in imagining worst case scenarios, Department of Medicine physicians came together in teams to imagine a system that would be scalable, sustainable, and safe. And our goal today is to cover elements of this plan. Next slide, please. In a very compressed timeline with rapidly changing evidence and information by the hour, the Department of Medicine's membership did in days what would ordinarily take months. It started with an impromptu weekend sprint where we brainstormed and drafted a 30-page proposal that was then escalated zonally and provincially, where it was adopted and led to the first MEOC webinar all in a shockingly short time frame of 10 days. Next slide, please. Active inertia is an organization's tendency to follow established patterns of behavior, even in response to dramatic environmental shifts. So this is collective human nature. We get good at doing what we do, and we become efficient by doing good work quickly, which then usually gets rewarded with more work that we also end up doing well, and the cycle continues. So existing systems often have a hard time dealing with major external changes or threats because we are bogged down in large volumes of day-to-day work that we do quite well. So when systems need to be temporarily reassigned, redesigned, reassessed, or overhauled, it helps to have almost a skunkworks approach or some non-traditional group or body to temporarily steward the process because they bring fresh eyes to fresh problems as well as some additional time, they have time that existing leaders often don't because the existing leaders are already burning the candle at both ends on a day-to-day basis, even outside of a pandemic. And in fact, it is because of the skill and humility of our leaders that allowed this massive collective effort to emerge. And leadership humility is a form of resilience. Not only does intellectual humility help individual leaders be resilient, but it helps the entire system be resilient. Our department heads, Elizabeth McKay and various AHS and university executives, created space for this department to rise and scale. So humble leadership is one form of resilience. There are other forms of resilience that influence our capacity to surge. Do leaders have adequate FTEs allotted to do their baseline work? What about surges to their baseline work? And what about surges of pandemic proportions? Do we have enough beds and MDs specialized in acute care to look after a surge in sick patients? Sometimes we need to draw on areas of greater strength to bolster vulnerable areas. And this is no different than a hockey analogy where if a team has a strong defense but weak goaltending, we can trade a defender for a goaltending prospect. Similarly, we have a generous and highly skilled MD workforce in non-acute areas. So that is our strength. We also have world-class medical educators, another strength. So by supporting med-ed training of non-traditionally acute care MDs, we can build off an area of resilience to bolster an area of vulnerability. This capacity to recognize and act is a form of system resilience, critical to governing in crisis. And we are fortunate to have great leaders, great colleagues, and great educators to have recognized and initiated this process. Next slide, please. We didn't know how much time we had, and we didn't know how bad it was going to get. We saw images out of Italy and Spain and had no idea physical distancing was going to be effective. We were, and we are still learning about the characteristics of the virus. Why were healthcare workers dying? What would we do if we ran out of ventilators? What would we do if we ran out of PPE? So on a backdrop of fear, anxiety, and a time crunch with an imminent risk of health service load breakage, we created 6 working groups. This allowed a cross-pollination of ideas generated from each acute care site and various specialties, influencing both the design and execution, with clear lines of communication to facilitate rapid scale-up. The goal was to design a system that allowed teams to, 1, learn from the front lines. What's going well, what's not going well, and what ideas do people have? 2, to innovate and scale innovations and solutions rapidly across sites. And 3, to rapidly escalate challenges to high-level expertise and decision makers to protect and serve frontline staff and patients. Next slide, please. By name, the 6 working groups were physician and staffing. So Kaylee and Anna work on how to deploy MDs efficiently, safely, and at scale. Interdepartmental affairs, Paul, Prab, and Kim figure out how admissions, transfers, and discharges are handled between services and between inpatients and outpatient worlds. MD training, Raheem and Irene develop innovative methods to train non-acute care docs to do acute care work and to train acute care docs to do acute care work better. Clinical practice guidelines, Carrie and Leanne work with partners in literature to ask and compile questions critical to clinical care and help get clinical trials to our patients. MD Safety and Wellness, Jane and Shannon work to procure a full range of assets to keep docs safe and healthy. Communications, Paul and Megan develop and implement systems to get field logic from the front line to decision makers, anything from ideas, problems, and successes. Then they communicate answers, policies, and new information to the front line reliably, predictably, and with a high signal to noise ratio. Since 20% of the department is part of MEOC, there's been a wide range of skills and expertise being drawn on, and this is the reason for MEOC's success so far. The most important takeaway from this slide: when we say MEOC did this or MEOC did that, remember MEOC is a composite product, a unity of effort presented by everyone on this structure and their teams. And MEOC, of course, intersects with existing structures, site chiefs, quality improvement, clinical informatics, AHS ops and planning, such as medical affairs. This is a team effort, and the org structure is merely an organizational tool, not a hierarchical one. Next slide, please. Our fearless leaders who have mentored us every day through their actions, remarkably clear, kind, and consistent in the face of challenging decisions and sleepless nights every night. Next slide, please. Two linchpins of the department, our department manager and program manager, without whom we would be drowning in a lifeless ocean of despair. They keep us on track. They highlight our blind spots, of which there are many, and provide many reflective insights. Next slide, please. We are lucky to have a collaborative, insightful, and hardworking acute care site lead group from the hospitals where we are expecting the bulk of patients to be admitted. Ward, Leanne, Ian, Anna, Fiona, Ralph, Troy, and Brendan. So much of their hard work is behind the scenes. They are the hospital's engine. Next slide, please. We're also fortunately supported by stellar cast in programming support and administrative support. From top left, Lanza, Nathan, Craig, Brandy, Sandy, Tara, Chris, Robert, Rylan, and Jovina, who, like Prince, is both a genius and legally represented by a symbol rather than a name. Next slide, please. The communications group, working group is overseen by Paul Gibson and Megan Elliott. Next slide, please. Paul and Megan are supported by Stephanie Smith and Adam Papini. The principles of the communication vertical are to convert tacit communal knowledge into explicit, actionable feedback, build trust by listening, acting, and communicating, and enhance wellness by reducing frustrations and problems on the front lines. If governance is the hardware, comms is the software. Next slide, please. Comms has orchestrated a mix of inbound and outbound communication. So we developed a new website, frontline feedback through online forms, and a daily bulletin to communicate with our members. The website has seen about 975 independent users in Calgary and another 150 from rural Alberta, with 150 more from the rest of Canada, and a smattering from the US, which we like to assume is Dr. Fauci and team. This is not just a simple website. There are many places where policies, procedures, and processes are generated within AHS and within MEOC, which means developing and maintaining the site is no small feat for the admin team and the comms vertical. The site is rather link heavy, but meant to be a point of care, one-stop shop. And the MD training and communications team are constantly working on improving its usability. The teams work incredibly hard. We garner frontline feedback twice a week and escalate that information to appropriate teams in AHS, either to inform care processes or to troubleshoot problems on the ground. We try to answer these questions indirectly using the daily bulletin, as well as directly to the person who asked. In 3 weeks, we have had about 48 people complete the frontline feedback forms, which is quite impressive. Getting docs to fill out any form is hard. So 48 is phenomenal and speaks to the trust our comms team has built with our members. It also tells us our members care and want to contribute to quality of care and are actively engaged in pandemic care and planning. The bulletin contains new or updated drafts of care pathways, policies, processes developed and training modules developed, which will be covered shortly. So when Raheem and Irene have a new educational tool, it goes here. When IPC comes out with a new universal masking policy, it goes here. When Carrie hosts a webinar, it goes here. When Kim, Prob, and Paul complete a process map, it goes here. When Jane and Shannon have a wellness tips, they go here. This isn't the only way policies are communicated, but it is the way MEOC streamlines communications. This is also where our webinars are advertised. And we have seen 800 to 900 attendees at our two public-facing webinars, one by the MEOC leads and one by Carrie's CPG group. Next slide, please. These webinars have reached docs across the province, and we have Kelly Barak and his team to thank for all kinds of critical support. from helping presenters make polished slides and images, to using seamless technology integration to reach thousands of physicians from across the province. We literally could not have done this without you and your team. So thank you to Kelly Burek, and thank you to the team. And next slide, please.
So I'm going to spend a few minutes talking about the staffing model. So we had this this anticipated huge surge of patients coming into the hospital, and we needed to really think about how we were going to provide care from a physician workforce perspective. So I'm going to share the work of the people that you see on the screen here. Kaylee Shukalek was the lead of this team, working with Dr. Anna Purdy, and the four gentlemen below, John Walsh, Steve Duncan, Ralph Hawkins, and Brendan Kerr were the site schedulers who were integral to the planning and the organization of this work. Next slide, please. So we, as you've heard, we were looking at a volume and pace of demand that was quickly expected to outstrip the existing acute care physician supply. Add to that learning from other centers, we knew that if a physician was exposed to a patient with COVID without the appropriate protection, they might be isolated for 10 to 14 days. Even worse, they could become ill and be unable to work. And we factored in that this might lead to a reduction in our workforce by as many as 20 to 25%. So we very quickly realized that we were going to need help from outside of our department, outside of our traditional acute care physician services. We would need to recruit from outside of our usual teams. But it also led to us thinking about a way that we could develop an innovative model to increase capacity. And as Aleem mentioned earlier, our motto was it needs to be scalable. So we need to be able to be responsive and move and deploy teams or deploy physicians in a way that was responsive to the demand. It needed to be sustainable because we didn't know how long this was going to last. And importantly, it needed to be safe, not just for patients who were receiving care in the hospitals, but also for physicians themselves. Next slide. So we devised a pod structure. And to orient you here, a pod lead would be a physician that is typically working in an acute care setting, looking after the types of patients that would come in with COVID-19 or suspected COVID-19. And then pod physicians or pod MDs. These are physicians that have expertise in areas outside of acute care medicine. They're often working in the community. They may be working in hospitals, but not typically the doctor providing direct care to patients with acute respiratory illness. So we set up a pod structure where we partnered physicians who had the acute care expertise with physicians who had expertise in other areas. And this served a few purposes. One, as you can see here by the distribution, I'll walk you through in a moment, it distributed the acute care expertise across a larger number of patients. So a pod lead might be able to look after 15 patients by his or herself. But if you actually took those 15 patients and had a pod physician look after them with support and guidance from a pod lead, then you would actually be able to have one lead physician help with the management of up to 60 patients. And that becomes scalable if you have two such pods, 120 patients and so on. Recognizing though, very importantly, that patients with COVID-19 or a suspected COVID-19 also come into hospital with their own list of medical problems, their diabetes, their heart disease, their high blood pressure. We established this team structure to facilitate cross-pollination amongst experts in other domains who were coming to provide care to these patients in hospital. And so in a way, it was a supportive structure for every physician that was involved. So we really tried in our model to think about how we might complement the expertise so that we could provide comprehensive care to a large number of patients in a way that was, as I mentioned, scalable. Next slide. So the other piece of this, in addition to the way the teams were structured, is the way that the shifts were structured. And so we took learnings, best practice from other epidemics, Ebola being a notable one, around what do shifts need to look like? What does the structure of shifts need to look like in order to prevent physicians from becoming overly fatigued, which has obviously implications for patient care, but also implications for errors in personal protective equipment, which can lead to illness and isolation. And so the need for isolation and removal from the workforce. So using those learnings, we set a shift duration of 8 hours, which would typically be a 24-hour work shift. So now we would need 3 physicians for every one, whereas we would previously have only needed 1, we would now need 3 physicians for a day. We also limited the number of consecutive shifts to a maximum of 4 at a stretch. So 4 days, for example, of 8-hour shifts, with an interval between rotations of at least 3 days. So within a week now, instead of having 1 physician working 24 hours for 7 days, which would be a more typical structure for being on call, we now need 3 physicians in a day and 2 different physicians for each of those shifts during a week. Factor in a buffer for physician illness, as I mentioned earlier, and suddenly a pod of 5 physicians actually requires 36 people to serve that role. And so again, when we projected that we might need perhaps 10 of these pods in the city, we realized that we were very quickly going to need more physicians than we had even in the entire Department of Medicine, which is about 440 people. And so we needed to consider recruitment from outside. Next slide. So working with our colleagues in Calgary Zone Medical Affairs, we put out a call, and we were overwhelmed with the volunteerism of physician colleagues on very short notice. Within 24, 48 hours, we had many physicians, over 800 ultimately registered. These are physicians working in other departments. They were sort of volunteering their time, not just to do the acute care work that we were asking for help with, but there's lots of COVID care, if you will, that was happening in the community, follow-up, management of all the other problems. There were a lot of different pieces that needed to be filled here, and so there was a huge outpouring of volunteerism. We had many of these physicians. There was sort of a logistical process of hospital privileges and licensing and things like that needed to happen. So many of these physicians are at various stages of that process. I'll add that some of these physicians don't work in hospital environments. They don't work, some of them are even retired. They don't work with adults. So we had a huge volunteerism from the Department of Pediatrics. But as I say, they were going through these various steps, and we had a few physicians that actually were able to get onto the wards, do some orientation, even if the patient numbers weren't high, with this idea that early experience when numbers weren't super high would provide benefit down the road when the patient demand really increased. And this quote was one that came from a colleague of ours who did a shift as an orientation. She said, "The orientation shift experience was great. Once I was at the hospital, practiced with PPE and saw patients, it was way less scary. I felt totally supported the whole time." So for us, this is a doctor that doesn't typically look after this type of acute respiratory patient, but felt very supported and well-oriented with the process. So for us, a validation that the model we were proposing seemed to be working, at least in the early stages. Next slide. So there were some additional considerations that we had to think about. So at the zone level, Gabe mentioned some of the zone level structures to sort of manage bed capacity and sort of figuring out where the patients were going to go. This was being done at a zone level. So although we had staff at different hospitals, we knew we had to be responsive to the needs of the hospitals. We might get a call from South Health Campus, where we don't have as many physicians, to staff units that are a group of patients that was much more than the capacity there. So we developed the teams in a way that was site agnostic. So we could plug them in wherever they were needed, even if it wasn't at their own hospital. That was the premise of what we planned, and that required some central coordination. Another issue was around scheduling in the face of uncertainty. We had asked physicians to volunteer for care in a very short period of time, notwithstanding personal and professional commitments. And we had to figure out when was the time that we were going to actually need these physicians, how well could we plan into the future. If we were scheduling doctors, how could we communicate with them when we might need them or not? And so we worked with statistical modelers from Alberta Health Services Analytics Department and Cummings School of Medicine Center for Health Informatics to help refine projections so we could at least get a 1 or 2 week projection to give docs an idea. Are we going to need you or not? Are you in a schedule or not? Are you a backup? Those sorts of things. And that helped us to figure out when we might actually need to put doctors into the hospitals. Physicians in training are a critical part of the healthcare system, and they really help tremendously on the acute care side. The initial models didn't incorporate them, largely because we knew that those doctors would be working in other areas of related to non-COVID care. But we had ongoing conversations with our residency program directors and our postgraduate medical education office to figure out when was the right time and how would we bring those doctors in if the numbers of patients required it. And the last issue that we had to think about, there were many, but another one I'd like to highlight is remuneration. So the model that we were proposing was not supported by traditional remuneration structures. And this was a time of uncertainty about healthcare funding. And so there was a lot of advocacy and work that went into just thinking about those problems. So beyond the spreadsheet, a schedule is about, next slide, please. A schedule is about putting people into slots, but we had many questions that came up. How do we support our physicians to provide safe and effective care? How do we promote mental and physical health? How do we foster efficiency in high demand, high turnover situations? Next slide. Physician safety is a really important piece. There is a risk that physicians, if they are exposed without adequate personal protective equipment, if they're exposed in a high volume, high turnover situation, that they might transmit the disease to patients. They might themselves become sick and make their families sick, and that results in fear when you're in the workplace. And we might actually lose physicians in our workforce planning. There were many factors that went into mitigating that: the designated units, the staffing model that I discussed, and the effective use of personal protective equipment was something that we really felt was important. Next slide. I'll just highlight some of the training that went into this work. I went into supporting doctors, led by Rahim Katra and Irene Ma as our leads, with a group of physicians that also helped them in developing some of the tools. Next slide. So PPE training was a really important piece that we felt was recommended for all physicians. There were online modules that we established, Rahim and team developed, and also in-person simulation. I'll credit Dr. Altaba, who's pictured here, with running a lot of those sessions. With thanks to Dean Meddings, we were able to rapidly expand the capacity for simulation training and enrolled and put a lot of people through, a lot of physicians through in a very short time. So over 200 physicians in a period of about 3 weeks. So this was a testament to the high quality products, the volunteerism and enthusiasm of the docs, and the support from the highest levels of medical school. Next slide. Another domain related to safety, another important dimension, is wellness, led by Dr. Jane Lemaire and Dr. Shannon Rizicki. Next slide, they helped us to develop a lot of different tools to address common feelings that physicians report: exhaustion, being overwhelmed, anxious, but motivated and hopeful and wanting to help. This was an unprecedented time of change and uncertainty, and in a lot of fear and apprehension, there were a lot of emotions that were coming to the forefront. Next slide. Just briefly to talk about some wellness initiatives and partnerships with organizations like WellDoc Alberta and the Alberta Medical Association. There were many physician resources available on our website, lots of hospital-specific information around sleeping call rooms, nutrition, showers, and additional information about childcare, a very practical concern, insurance, another very practical thing that physicians are thinking about at this time when they're looking at potentially working long and hard hours in the hospital. Next slide.
Thanks, Sachin. And so from an informatics and clinical processes perspective, this is really a cross-cutting discipline that's informed by the work of the entire team. But some of the main prongs are standardized order sets. So, for instance, these are basically airline checklists in the way you might think about them that we use at point of care to make delivering the right type of care at the right time the easiest thing to do. Those order sets have been informed by a whole team provincially from AHS that helps govern the content across our entire system. More locally to people like Tom Rich, who's our Associate Chief Medical Information Officer, and are now being shepherded by Dr. Carrie Johansson and the Clinical Practice Guideline Group that I'll mention shortly. We built some tools to help improve our situational awareness and system about finding patients that might be getting sicker. Some of those are reflected in the order sets we use, but then Ryan Lenz and actually one of the pediatrician informaticians, Dr. Jonathan Durant, helped in configuring our patient list so that we could quickly identify patients that might be getting unwell. we've built clinical documentation tools through the CPG group and through the expertise of people like Dr. Megan Blashert in helping us to better employ some of the electronic documentation tools that make sure that we are documenting against the right things that could help us with information communication about complex patients. Next slide, please. I'll touch quickly on the clinical practice guideline group. This is a really big group, actually, that is being stewarded by Dr. Carrie Johansson and Dr. Leanne Remke. They are responsible for really scouring the world's published and gray literature to keep our physician community appraised of current approaches and treatments. As I mentioned, they're complemented by many provincial structures and other knowledge supports within our province. Next slide, please. And these are just some of the people that are supporting that work. Dr. Kirsten Brown from infectious disease, Zara Guzzarzi from geriatrics, Glenn Hazelwood from rheumatology, Carrie and Tara and Alain and Kristen from respirology, Leslie Skeeth from hematology, and Selena Al from intensive care. And the other major prong of the approach of that group is to help coordinate the involvement and deployment of clinical trials. And this is maybe one of the single biggest things that we've been afforded by virtue of the time that you have all purchased us. I don't know that we would have had the time to really participate in the fulsome way that we're going to in trying to generate more knowledge about how best to treat this thing. But a number of trials here. So Alberta Hope being led by Michael Hill, Luann Metz and others. That's an Alberta-led study. There's CATCO, which is the Canadian arm of a Solidarity trial being led locally by Alain Tremblay. There are trials. Concours 1 is one they might have heard of using convalescent plasma. Covaprone is another local trial being led by Jason Weather. All of these things are ways that we start to sort out the best way to help treat our community members when they fall ill. And again, wouldn't have been possible without the time that the community at large has purchased for us. Next slide, please.
Okay, so home stretch. The last thing that we realized we had to do was, like I tell my kindergarten child, work well with others. And so a lot of our work was focused within the Department of Medicine, but this team here worked really hard to ensure that our care was integrated with the other critical frontline care services. Next slide, please. So this is just a figure that shows you, a schematic of what flow through hospital is like. The red box is us on the wards in the non-ICU care beds, and that's what we were tasked with. And working closely with our partners that are hospitalists, we share the care across the city traditionally for these patients. But we had to figure out care algorithms, bundles, checklists, ways that we could manage much higher volumes through the emergency department, working to escalate care when people got sicker to the ICU, transitioning people out of the ICU as they improve. Some unfortunately do pass away in hospitals, so working with our palliative care colleagues. And then an immense effort was put together by many people, led by Problail and others, to try to figure out what is the safest way to get people home and what are the supports that they require at home. So this is working with primary care networks, specialty colleagues, changing the rules around home oxygen, rehab facilities, etc. Next slide. So to wrap it up, this was a whirlwind of what we, and as you could tell, it was a bit of a pat on the back for all of the unsung heroes. The four of us were very uncomfortable with the whole notion of us being presented as the ones that did all of this work. And what we tried to do was show that, we're, like we said at the beginning, we're a small piece of a much larger pie. We're, even within the health system, we're a small piece. And, as Evan had alluded to, or has explicitly said, this is unprecedented. That's a word that we've heard many times over the last couple of weeks or a few weeks, and it truly is. I mean, in public health, we all study the Spanish flu pandemic of 1918, and this is the last time we've, as a globe, collectively, we've been impacted by a virus to this degree. I'll leave it with the words of our fearless leaders in public health. Dina Hinshaw in Alberta and Teresa Tam, both who I think are just outstanding leaders and are taking on massive jobs. And to summarize both of them, they tell us that, you know, we are doing these sacrifices together. The fight is far from over. This is not a victory lap, and we are not quite there. It is very difficult, all of us collectively and for society. There will be a lot of changes and there will be a reckoning to come at the end of this, but we really, we don't want to have all of that sacrifice thrown away by letting up early when we still have, as Teresa Tam said on the National 2 nights ago, you know, we're 10 kilometers to go on this marathon, and we're hitting the wall, but we're close, and we need to continue. We do feel that the inpatient, and part of what we wanted to relay today is that we do feel that collectively the inpatient side, the acute care side of the healthcare system is ready. And I will personally say that inside the machine, going from research and being a clinician to inside to operations, I have never in my life ever seen such a massive logistical and collective effort with a collective focus as I have been witness to in the last 7 weeks. And all of that, the hope is that what we're trying to do is provide a little bit of reassurance that there is a lot of going on, and that the healthcare system has been working very hard, and that is, if we all collectively continue to do what we're doing, that we will get through this in very good stead. Next slide. And that is our city. Thank you to Calgary, and 14 minutes to go for questions. Thanks very much.
Thanks very much to our speakers. That was wonderful. So we'll now switch to the question and answer period. And I have a nice question here from Dr. Jamie Day from the O'Brien Institute. She writes, a few years ago, the O'Brien Institute hosted Carolyn Toohey, who wrote a book about health systems, evolutions, and revolutions. She reminded us that the revolution of Canada's healthcare system becoming universal arose thanks to the world wars. She and others have advised that we should never waste the opportunity provided by an emergency to push through improved policies and practices. So the question to you is, have you seen examples from Alberta's whirlwind health systems in response to the pandemic of potential long-term improvements that should be maintained rather than scrapped once we start moving, quote, back to normal from the current pandemic situation? So I hand it over to you, gentlemen.
Anyone? Okay, I'll start. I agree 100%. A book that I loved reading many years ago was Naomi Klein's Disaster Capitalism. And in that book, her and others say, never let a good disaster go to waste. I think one of the most fascinating things about this pandemic is that the hospitals are empty, and we wonder where are the patients. We have seen dramatic improvements in efficiencies. I think one of the qualitative sidebar comments is that the camaraderie, the collective collegiality, and the efficiency of the healthcare system we've seen has improved. I think there's dramatic, one that I will point to specifically is, and this is in the outpatient space, so outside of our purview, but was, just the massive and rapid acceleration of video appointments and telephonic appointments. I think that's patient-centered. That was something that was being pushed along, but I think collectively, I think we can all hope that gets continued to be pushed on, because it's improved efficiencies both for patients and for clinicians. So I'll leave that as one example.
Okay. Does anybody else on the group want to answer that question? Aleem?
Yeah, so I mean, I think there are several components of the plan that has been presented that I think could be translated into ongoing systems. Some of it's accentuating stuff that's already happening that physicians weren't necessarily participating in. The RLS reports is one example of that. And then I think there's specific modules. You look at a lot of the medical educational modules, the PPE simulation. I think these are things that could go long term and improve care long term. Scalable models that can be surged as volumes change, especially influenza season and down future pandemics. I think there are elements that can be refined, evaluated, and sort of scaled up over time. And I think a lot of the communication structures as well. I think there are elements that would not work in a general system, but I think there are elements that would. And I think it's going to be important for us to figure out which of those might be sort of pursued, and which might need to be pursued, but with sort of modifications contextualized to our usual day-to-day life. And I think, we're looking at different ways to evaluate what we've done, like what we MEOC, sort of the holistic team, has done. And in doing so, I think we'll be able to better understand what sort of recommendations we would need to take forward. And I know our department leadership is already thinking about that and making active moves about that.
Yeah, Evan, did you want to answer as well?
The only other thing I would add to what's been said is it's just been so demonstrative of the value of unity of effort. And I think, in healthcare, we often have a lot of people with aspirations around improvement. I mean, it's a huge part of what we do. But these are often all kind of working, sometimes at odds or against one another, in competition for certain resources. And if we, I think this really highlights that if we were able to better prioritize or achieve that unity of focus to address some things sequentially, that we might actually take, steps more constructively around care improvement. Just because we're able to kind of to really kind of focus a sprint on one problem at a time. It's been something that I've been reflecting on.
Okay. And second, do you have anything else? Does anybody else want to add anything more?
No, I think that captures a lot of the main things. I mean, I think there are many processes within the hospital that, when we start thinking about efficiency of care and being able to deliver care in a way that can be scaled, and certainly when we think about inpatient services, and it's pretty tiring to be on call. So if there are ways to make that process a little more efficient, that can certainly help from a safety and wellness perspective. But then, as Evan says, in parallel, there's also the organizational sort of quality improvement aspects that are obviously relevant to what's happening in the hospital, but are about how it's organized and how it's delivered. And I think just that one of the observations I made was just how you have a lot of people involved. They all bring unique skills. They all bring different lenses to the problems that we're trying to solve. And that ability to, come together, talk through problems. We had these verticals, as Aleem mentioned, these sort of working groups, but we had lots of cross-cutting work that happened as well. I think was really neat to see, actually, from an organizational perspective, and I think will have impacts. So it's a bit more of a general comment, but lots to learn that we could implement.
And I think that there's an awful lot of interest right now in thinking about some of these positive changes that have been made into the healthcare system, particularly with the Ernst & Young review that we've just had of Alberta Health Services, and sort of the request to the system in general to think about, how can we deliver care more efficiently. So some of the lessons learned that you are doing right now will be very, very important for the future. So I have now another question. This is from Dr. Nishan Sharma. He's wondering if you had time to look at what other health systems in other countries were doing when you created the plan for Calgary. If so, what places? And he is very much congratulating your work as well.
So I'll start because, my early job was to read all of the literature as fast as possible, which quickly became impossible. And yes, in those early days, I was, partially because I spent 7 days at home in isolation and I was feeling helpless. So we took models, we read about Singapore, we took models, and so the safety models, for example, and some of the safety protocols came from Singapore that we tried to incorporate, that had some of the lowest healthcare worker infection rates in the world at the time. The staffing models we took from Global Health, we took from Ebola epidemic crisis zones from Global Health, of stuff that was in my academic purview, because when I looked in the literature, there was no staffing models. There were no models that we could quickly pop off the shelf, as you say in your question. And so we adapted some of that. We also looked at what was happening in Italy, and we also looked at worst case scenarios. We looked at Italy, and we looked at they had very high healthcare worker infection rates. And at the time, as I think Aleem alluded to, the evidence was moving so fast, and this was, in health services, this is a chaotic system. So there was unmeasurable unknown unknowns that were moving very fast. And so we used literature where it was, we extrapolated where we could, and then we invented and refined as we went in places where there was nothing. And to your second question, which I personally enjoy, is that we've actually been the ones that sent out our document to multiple departments of medicine across the country. We've had many people request our materials. And I think that's, again, because of the many people that helped us contribute to putting together something, but also because we were bought time so that we were able to put together a comprehensive plan.
So that's extremely important. That's wonderful to know that you've got that documentation and that you've already been sharing it with other groups. Does anyone else want to add anything to that question?
Maybe I'll just make an additional comment. I think, as Gabe says, you know, there were some pieces in the literature from previous, you know, epidemics, disaster scenarios around staffing and the other considerations that need to go into it. But we were, you know, ultimately pulling a little bit from here, a little bit from there, trying to build it all into, you know, kind of a more comprehensive model. But the other thing I'll just highlight is context. And so this is new. This was new. Lots of people thinking about it, but in terms of how we sort of structured the staffing, there were some untested pieces. And I think it just speaks to the importance of that bidirectional communication. And just, you know, we talked a bit about quality improvement and how important that is for us to understand like what's actually happening on the ground as we start to put these pieces in. So there's learnings from other places and then kind of paying it forward by evaluating it locally and then sharing elsewhere.
Anyone else want to add anything to that particular question? Aleem?
At the heart of this question is the notion that the Cummings School is a global citizen, and the O'Brien Institute, you know, an exemplar global citizen. Not only are you contributing and learning locally with our local communities, we're contributing and learning at a global community level as well. And as the world emerges, not only from the COVID crisis, but as the world continues to evolve in the accelerated trend it's already trending to, this notion of community and global citizenship will be what helps us thrive or not going forward. And I think we need to spend time better understanding how we learn to, what these citizenship responsibilities are, how we can contribute, how we can learn in order to improve the lives of our citizens here and elsewhere as well. And I think that bears study and bears future study and bears future learning and implementation, which is, I think, you know, to answer, you know, Jamie's initial question, additional elements that we can extract from this to take forward.
For sure. Okay, that sounds good. We have another question here. For COVID-19 testing, do you collaborate with doctors of veterinary medicine as essential workers with their CL2 licensed available laboratories and trained staff? Did you reach out to them for help for the COVID-19 testing? They emphasize one world and one health approach.
I mean, I can speak to this quickly, only to say, you know, one of the things we've tried to emphasize here is that we've played a smaller part within a bigger health system, and that, you know, some of these things around, you know, laboratory assets, for example, are areas where we wouldn't bear considerable influence, but we also defer to the experts. So it's something that's certainly kind of been outside of the purview of our control, as physicians kind of largely responsible for organizing and training a physician workforce. You know, it's good to know that, you know, that capacity could be there, and I hope that that the people who are running those facilities know that.
So I can speak to a little bit, again, outside of our purview, but just interacted with. So the university has been very involved in coordinating and donating resources, reagents, staff, and work to the health system. So I know that the university emptied its research laboratories of all the many material, PPE, reagents, etc., to assist in the efforts, especially around testing is one. And so in that way, the answer is yes. That veterinary medicine, as much as the rest of the university, has definitely participated.
Excellent. Do you have any closing remarks that you would like to make? Any more thoughts about like where you're going in the future from now on? Because we're still midway through this pandemic. Are you still evolving your systems and methods and approaches?
Yeah, I mean, we have this conversation every day about none of us have a crystal ball, and we all stare at the numbers every day and try to read the tea leaves and tell us where it's going. I think we're going to try to hold the line. I think we've bought time. You know, society's bought us time to prepare in the inpatient world. The case counts are still going up, but at a slow pace that's manageable. There are unintended consequences of hyper-focusing on COVID. There's other aspects of the healthcare system that have been halted. We need to understand when and how those components can be reopened and what are the consequences of such. We don't know if there will be a second surge. I mean, there's many pieces. When is the vaccine coming? The serologic tests that we need to get true prevalence estimates for the society. There's so many components that are ongoing. We've largely handed over the operations, operations back to the system that exists, and now are moving towards QI to refine the processes and test them, and to, you know, do some writing to document what we've done, so that there is a plan, you know, in the future if someone else needs one, including ourselves. I think I'll defer to the others, but that's kind of what we've been doing for this of late.
Thank you very much. Any other closing remarks?
I'd like to just add that, you know, it's something that Aleem said there really hit a chord with me, and, you know, he mentioned that the responsibilities of citizenship. And if there was one message to leave people is to really sustain one another through this. You know, if the first phase of this was, you know, about a disease network in the flesh competing against a social network of influence and policy that help, you know, keep us apart and hold the line. I think we've shown that we can slow the former with the latter, but you know, aside from this virus kind of tearing at our hearts and lungs, I think the real threat now is that it tears at the social bonds that hold us together, because the suffering in achieving those types of policies is not equally distributed. And so find ways to sustain one another, sustain your community. There are some great efforts locally in Calgary, whether it's through the food bank, there's PPE drives, you know, that are all kind of coordinated by people that are very kind of close to the physician community too. Those have become, I think, more and more important locally, but also globally, as Aleem referred to.
Well, thank you very much. I think I will be closing off our seminar right now. I just wanted to thank all 4 speakers for an outstanding presentation. And thank you for the wonderful work that you're doing on behalf of all of us who were attended today and had the great pleasure of listening to your presentation. And good luck with what you're doing.
Thank you.